Hi, everybody. So we find ourselves in 2023, and this will be our first ECG analysis for 2023. And I'm hoping next week that we'll do some X-rays, and then I want to start a new series on the blood gas. So hopefully we'll start that the week after and keep it going for because it's quite a bit. It might take a month or two to finish. So hopefully we'll get to that. But anyway, since it is the first one of 2023, I didn't want to overburden you. So we're going to start off with one that's relatively easy. So here we have a 21-year-old woman with chest pain. And remember, for those of you who may have forgotten, we always analyze the axis. We analyze the rhythm by analyzing the P waves, the PR interval, our QRS width, our QRS regularity, PQRS regularity. Then we analyze the rate, and then we go through each zone. Okay, for those of you who may have just joined the group or are new, if any of this sounds confusing, please go back and have a look at our ECG basics lectures, and then we'll take it from there. So you've got a 21-year-old woman with chest pain. So the first thing is, of course, I always tell people, imagine that you're, we're having a bit of a rest in your car at 2 in the morning or in the call room, and you get a call like this from the nurse who's on the floor, or your junior who tells you, listen, we've got a 21-year-old complaining of severe chest pain that started about an hour ago. Patient not feeling too well. Now, the first thing is you have to take in consideration age. And as we've realized in the last few months, we can't discount ischemia. We've been finding ischemia a lot in younger people as well. Depends on body habitus. There's a few other factors. But in any case, so whenever you have chest pain, you always think of cardiac ischemia. Then you've got to think of cardiac infections. And then you've got to think of cardiac inflammation. And when we talk cardiac, remember we're talking about endocardium, myocardium, pericardium as well. And then, of course, you look at the lungs. So you're talking about infection, inflammation. Are you talking about the surrounding structures? Are you talking about the esophagus, the mediastinum, the ribs? So you've got to have something in your mind. So here we just have a 21-year-old with chest pain. So you go, you examine the patient. Part of your workup must be the ECG. Now, let's have a closer look at this ECG. All right, so let's analyze it. So let's have a look first at our axis. So we've got our axis here. Let's draw it out. Oh, sorry. Let's get a straight line. So let's look at the axis here. So remember, we look at lead 1. So just put that here, lead 1, and lead AVF. Let's put AVF down here. So remember, let's just change the color over here. Nice blue. Good. Make it a bit thicker. Yeah, okay, let's make it a bit thicker. So we've got lead 1 pointing upwards. So if you watch the basics lectures, then you know, right? So we're talking about electricity moving in the direction of lead 1. So lead 1 is seeing it come towards it. So that means we've either got a left-sided axis or the normal axis. And for those of you who have forgotten, this is the extreme right axis, and this is the right axis. Okay, so we're looking at either one of these. Okay, so we can immediately discount and say, okay, we don't have an extreme right axis, and we don't have a right axis. So we're dealing either with the left or the normal axis. Okay, so that's what we're looking at. All right, let's go back to the other one that we were using. All right, and then let's look at lead AVF. So lead AVF is also positive. So that means lead AVF also sees electricity moving towards it instead of away. So that means we can also discount a left-sided axis. Okay. It actually looks quite nice. I didn't expect that. So we've got a normal axis. Okay. So yeah, so that's the first thing that we look at. So a normal axis is a good start, but it doesn't mean everything's okay. Let's have a look at our rhythm. All right. Well, in this case, we can even have a look at the rate first, just to speed things up. So remember, we're going to count now. This is the old-fashioned way. On ECGs now, you have the printouts telling you almost everything, including the diagnosis. But anyway, let's go. So we're looking at 1, 2, 3. 300 divided by 3. So we're looking at about 100 beats per minute. So we've got a tachycardia. So let's see what type of a tachycardia we have. So first, let's look at our P waves. So our P waves are a bit small, But you must remember the height and width of the P waves, unless extremely exaggerated one way or the other, in other words, extremely flat or extremely peaked, these can be within normal. There's a lot of other factors that go into it. But in any case, these ones here don't look 100%, they don't look good, but they are there. Okay, so we do have P waves. So we can see that we are having a sinus tachycardia, but we'll get into that just now. Let's look at our PR interval. So we look at our PR interval, we see that we're looking at about 1, 2, 2.5, just 2.25 blocks. So we're within the normal range, but just barely. Okay, so remember, less than 120 milliseconds, and you're looking at a shortened interval, right? Or rapid re-entry. Yeah, I think I said that right. Okay. So relatively normal PR interval. We've got narrow QRS complexes, which means that the QRS, in other words, the ventricle is responding to the sinoatrial node. And does a QRS follow every P? Yes, it does. So we have a ventricle that's, what you call it, beating after every atrial beat. So that's good. That means there's good conduction. And if you look at this, there's slight irregularity, which is sinus arrhythmia, which is something all of us have when we breathe in and out. Okay, so but it's a very small variation of 2 or 3 beats per minute at times. Now we're going to get into the abnormalities that we see just now, but just talking about rate and rhythm. So we've got a sinus tachycardia because we've got a normal rhythm, but it is a tachycardia. All right, let's look at each zone. So let's start with our inferior zone, which I always like to start with. So remember, leads 2, 3, and AVF are the ones that we normally look at to have a look at our inferior zone. So that's the bottom of the heart. So as we're looking at the bottom of the heart, we can immediately see these ST elevations. All right. So this should immediately start telling you, listen, this is cardiac, that's for sure. Right? So we can see that, over all of them. And we see these P wave inversions over there, which are not necessarily something that you should worry about the majority of the time, but they are a bit worrying because it can sometimes point to rotation of the heart, enlargement of atria, things like that, although not in this case. But P waves are something very intricate, and unless you're going to become a physician or a cardiologist, I wouldn't suggest getting too stressed out about it. But it's always a good thing to learn over and beyond what I teach you guys. Okay, so we know there's something going on, right? Let's have a look at the right side of the heart. So if you look at AVR, then what we see is that we have these. I suppose you can't call them ST depressions, but they're very slight. If we had to look at our line, which is the zero line, our isoelectric line, it is definitely below that. And the other thing we notice is that this PR, the PR line is actually elevated, the PR segment, okay? All right, now we're going to come back to 1 in AVL. So we've looked at the bottom of the heart and the right side of the heart. You can see something's going on. So let's look at the septum. So in V1 and V2, V1, there's not much to talk about, but in V2, we can start seeing the ST elevation again. And remember, for female patients, more than 2.5 blocks elevated is a problem. So we're looking at 1, 2. So even though it's not a problem, it's not highly elevated, it's still an issue because we can see ST elevations in other areas. All right. So if for example, this was the only change that you would see, then you would say, okay, this could be benign early repolarization, which we've discussed previously. Okay. So in context, this is a bit worrying. Okay. So why does she have these ST elevations in V2? Then we look at the anterior part of the heart. And here again, we start seeing these ST elevations. Okay. And here what you start to see is this PR segment depression. So what's happening is, if this is the isoelectric line, so the isoelectric line is where the heart is not doing anything. This is just about half a block below that. And you can see it kind of mirrors what's going on. It's almost like a reciprocal change, okay? And we'll get to that just now, because then it tells us the diagnosis already, and we'll get into that. And for some of you who have been following these lectures for some time, you may already know the diagnosis, because I always emphasize on these few things. And then if we look at the lateral side of the heart, so first we're going to look at the lateral leads, V5, V6. Then we look at the high lateral leads, 1 and AVL. So in V5 and V6, again, we see this very slight but definite ST elevation, along with this PR segment depression. Okay, and then when we come across to leads 1 and AVL, which are your high lateral leads, and again, we see the ST elevation, PR depression. Okay, so what are the possibilities? So the first thing is that this could be a massive myocardial infarct because you've got the inferior section, you've got the septum, and you've got the lateral border and anterior border all all involved. Okay. So that's the first possibility. The second possibility is a ventricular aneurysm, right? And then the third and most likely possibility is a pericarditis. Okay. Now, why do we say pericarditis in this case? The reason being the PR segment depressions, right, which is quite common in pericarditis. Okay. Now, does it definitely confirm pericarditis? No. You would still do your cardiac enzymes because we don't know. Is there an underlying myocarditis as well? Are there some ischemic changes that are taking place? So you still got to do your basic investigations. But what you probably find in a lady of 21 years old, let's say normal body habitus, non-smoker, no family history of hypercholesteremia. And if you were to look at this, your first thought would then, after analyzing it, be acute pericarditis. How would you confirm it? So the easiest way that I found clinically, make the patient sit forward. They are in extreme pain. Make them lean backwards. Suddenly the pain is alleviated. The reason being, lean forward, myocardium rests on an inflamed pericardium, not a very pleasant sensation. Lean them back, moves away from the. Now, this doesn't mean that the posterior edge is not inflamed. It just more commonly occurs in the anterior portion and the lateral portion. So you just lean them backwards and it becomes more, it's more of a relief for them. Now, clinically, they say also that you can hear pericardial rub. I've been in practice for 20 years. The only time I've heard a pericardial rub is when I've read about it in the books. I never heard of. But for those who've worked with me before, it's also because I kind of just put my stethoscope on the patient to make the patient feel better sometimes. I think I've given up auscultation now for too many years, which is not a good habit. It's just that normally once I reach that stage, I've kind of already made up my mind. But that comes with experience. I wouldn't advise you guys should still just going through the patient. Okay. So let's have a look at what we've got, right? So as you can see, they're talking about ectopic atrial rhythm, right? The rate of 97 and acute pericarditis. So an ectopic atrial rhythm is diagnosed because of inverted P waves in lead 3, which excludes the sinus nodes as the origins of the P waves. Now, this is why I say P wave pathology can be very difficult. So it's not important to your particular diagnosis in this case, all right? So ectopic atrial rhythms, and there's quite a few atrial rhythms that come about, please do not stress about them. Generally, working in an emergency department, we don't worry about atrial abnormalities to a great extent. They are there, and there are the few exceptions. I've tried to keep away from them simply because they can get very involved. You can get very deep in the weeds on atrial abnormalities. And what happens is it very often takes you away from the emergency diagnosis. So, for example, if you had a patient like this, presenting in your outpatient department or presenting with chronic problems, these are the types of patients that you would send through to your physician, that you would send through to your cardiologist. They would need to do further studies, electrophysiological studies. They would then find out exactly what's going on. But basically all that it means, if we had to go back, is that once you see these inverted waves, all right, and in this case, they do talk about it in quite some depth in one of the other books. Maybe I should go into it and give you guys. But in any case, even if we don't, what they are basically saying is that the origin of the impulse that's reaching the ventricle is not the sinoatrial node. It's coming from somewhere else. That's why the axis for the atrium is inverted. Right? So it's a nice thing. It's one of those things that if you point it out during a ward round, somebody will give you a pat on the back, and you'll be way, great. You know what an ectopic atrial rhythm is. Or it's one of those things that you don't even have to remember, but you can kind of just remember it as like a buzzword. Like, I think it's an ectopic atrial rhythm, Mr. Consultant or Mrs. Consultant, and they'll be like, wow, you know what that is, even though you're completely wrong. So it's one of those things that you can okay. So in this case, the PR interval is normal, so it excludes an AV junction rhythm, which again is another a type of ectopic atrial rhythm. So we're just going to not worry about these first two sentences. Now let's get into what the meat of the situation is. So we have a diffuse ST elevation is noted. Okay, so let's have a look at what the causes are. So the causes of diffuse ST segment elevation include large acute MI, acute pericarditis, benign early repolarization. Now, in this case, I wouldn't have gone to that diagnosis simply because our patient is symptomatic. And number two, it was not as if you go back to the lecture that I had given on benign early repolarization, where we had seen a patient with that, then you would understand why. Right? Coronary vasospasm, which can be one of those, left ventricular hypertrophy can also be seen over there. And as I had said, ventricular aneurysm, which they have mentioned before, but even in this book that we have been following, but they just don't mention it in this. And then we notice the very subtle PR segment depressions, which we had mentioned, present in several leads, which suggests acute pericarditis. Now, there's a caveat to this. It suggests acute bacterial pericarditis, which they don't mention here. Now, why I say that is because I've seen people sometimes see this, and because they don't see the PR depression, they immediately throw out pericarditis as a diagnosis. Do not do that, because viral and autoimmune and TB, for example. TB does give you a bit of depression, it's true. But what I'm saying is you can't exclude those causes of pericarditis. So it's mainly acute bacterial pericarditis that causes this, right? Now, acute bacterial pericarditis is actually very, okay, I'm going to say very common. When I say that, what I mean is it's very common. It's a very common presentation that we see amongst those with chest pain. So it's not very common, as in you're not going to see one a day or two a day, but amongst your chest pain patients, you are going to see this relatively commonly, and especially with us in South Africa, because of the immunosuppression that a lot of our patients have been experiencing, the high levels of TB, poor compliance with medication, they're much more prone to bacterial pericarditis. Right? Now, of course, it depends on the amount of immunosuppression as well, but generally there is an immune response, and they do get this acute bacterial pericarditis. But then you get signs of bacterial infection as well. But it doesn't manifest early, so it's not an easy thing to become clinically. Right? So, and additionally, PR segment elevation is seen in lead AVR. Right? So this is what they're talking about. So we see all these PR depressions everywhere that we had mentioned, but specifically this PR elevation, which is a good indication that it's pericarditis, right? So this is when we come to that diagnosis. So that's why I decided to do this one again, because it's such a common presentation. And those are doctors who've been phoning me from the peripheral hospitals will know that I've diagnosed this for you guys quite a few times, and we've had to treat the patient. But remember, you're not treating an ECG, you're treating a patient. So make sure that you look at the symptoms, look at the signs, look at the age of the patient, past history, habits of the patient, all of that, family history, everything, and take it all in one big bundle before you make the diagnosis. But the ECG can give you a very clear view of it. So I don't want to overburden everybody. It's not a very long one today. And yeah, for those of us who work in the emergency rooms, we know how we deal with patients like this. So anyway, yeah, hopefully next week we'll have a look at pelvic x-rays, which will stretch over maybe 2 or 3 sessions. And then hopefully we'll start with the analyzing how do you guys go through arterial blood gases as well, which is something I wanted to do for quite some time, but just didn't get around to. So hopefully we'll be able to do that. Okay, I hope you enjoyed it. And yeah, hopefully we can have, next week, Thursday, we'll get together again for another video. Okay, keep well. Bye.